Hello, good evening. Welcome back to my AV Fences and the European Fertility Society. We are back with another topic, and today we will talk about PCOS and its impact on fertility. And to help us understand all aspects of PCOS and the impact on the fertility, we have invited Dr. Abraham Zavala. You can see him right here. Hello, Dr. Abraham. Lovely to have you. Hope you are ready to educate us and of course, also answer the questions, but that will be right after your presentation. How are you? Great to have you. This is your first time with my Avi Fences. Welcome.
Yes, and
Welcome back.
very happy to be here. So thank you for having me.
Thank you indeed. And let me just briefly say a few things before we start the presentation on our topic. Let me just introduce Dr. Zavala is a fertility specialist at Clínica Tambre, new location in Alicante. So there are two doctors, he just told me before that. So they are working really hard nowadays with patients, of course, so helping out with all the fertility issues. And of course, he will talk about PCOS today. He will start with his presentation, but afterwards there will be time for your questions. So remember, you just need to put those in the chat, and Dr. Zavala will simply answer them for you. And we will have around 30 minutes for the presentation and another 30 minutes for the Q&A session. So you can type the questions during the presentation or afterwards, and we'll definitely do our best to answer as many as possible. And remember, it's all being recorded, and I think that will be it. And we can start with the presentation. Ready?
Great.
Fantastic. There's the presentation is here. Please let us know that you can hear us so we can make sure and we can simply go ahead with our presentation. And let's go. I think everything is fine.
Great,
Thank you
great.
so much.
Well, good evening, everyone. I'm Dr. Abraham Zavala, a reproductive medicine gynecologist at Tambre Reproductive Medicine in Alicante, and I am delighted to welcome you to tonight's webinar on polycystic ovary syndrome, or PCOS, and its impact on fertility. Now, this is a topic that affects countless women around the world, and while it's often misunderstood, I am here to provide clarity and insights on this topic. So let's dive into the science, treatment, and hope for those navigating through PCOS. All right, so what will we be covering today? So first of all, we'll start by defining what PCOS truly is, and more importantly, what it's not. From there, we'll explore treatment options, especially for those considering pregnancy. Then we will discuss the different assisted reproductive technologies that we have available and the specific considerations for PCOS patients. My goal tonight is that we don't leave any stone unturned in terms of PCOS, and also to equip you with the knowledge um, to better decide what's best for you. All right, so first of all, so what is PCOS? So it's very important that we know that PCOS is the most common endocrine disorder, and yet it remains shrouded with misconceptions. To simplify, PCOS is characterized by hormonal imbalances, irregular ovulation, and often the appearance of multiple follicles on the ovaries. But let me be clear when I say that having polycystic ovaries, or ovaries with many follicles or cysts, we call cyst any fluid-filled sac in the ovary. So with many follicles or many cysts doesn't automatically mean that you have PCOS. In fact, being called polycystic ovary syndrome, whenever we see the word syndrome, we describe a constellation of signs presented together. So diagnosis requires a careful evaluation of symptoms, which we'll discuss more in depth in ahead of this presentation. So as I said, irregular menstrual periods, multiple follicles, and hormonal imbalances. This is what characterizes PCOS, but it's important to remember that some of these signs can be quite normal in adolescents, especially as they're having their first period. So specifically within the first year, they might have, hormonal imbalances that may cause hallmarks of PCOS, such as acne. They may have ovaries that have many follicles, and it's not infrequent that they have irregular menstrual periods. So it's important that we think of this population a bit differently when considering PCOS. So many people wonder what the causes are of PCOS. And while the exact cause of PCOS remains a mystery, we know that there are many factors at play. So things like genetic or epigenetic predisposition, insulin resistance, environmental factors, hormonal imbalances, and even things like vitamin D deficiency all play a role in developing PCOS. Think of it a bit of like a puzzle, in the sense that no single piece defines it, but together they create this bigger picture that we call PCOS. So depending on how you define it, or how we define it, it can affect anywhere from 6 to 13% of the female population worldwide, with certain areas having a bit of an increase in the incidence of PCOS. Areas such as Southeast Asia and certain parts of Eastern Europe have a bit of an increase in the amount of people with PCOS. All right, so the symptoms that we see in PCOS are going to help us identify it. And as you can tell from this slide, symptoms can vary widely, anywhere from irregular periods and acne to weight gain and excessive hair growth. Also, it's important to mention that non-physically apparent symptoms need to be screened for, such as anxiety and depression, because these can go along with PCOS. And importantly, not all women with PCOS are going to have the same symptoms at the same time. So this diversity is what makes PCOS so complex, and why a personal approach to treatment is essential. Okay, so I think that talking about how we diagnose PCOS is paramount to understanding it. So we have a few ways in which we can diagnose it, but we don't have a specific test for PCOS. So diagnosing PCOS involves looking for at least two of the following, which would be anovulation, which is the absence of regular ovulation cycles. Usually we think about having less than 8 cycles per year. We would be considering anovulation. Also having higher levels of male type hormones. We call this hyperandrogenism, which means that women, which usually have a small amount of male type hormones, have a lot more in PCOS. And as I said before, a polycystic appearance of the ovary when seen through the ultrasound. Now, these are what we call the Rotterdam criteria, and it is the most commonly used method to diagnose PCOS. Last year, we added that the AMH can now be used as an alternative to the ultrasound, in case the ultrasound doesn't give us that clear picture of polycystic ovaries. Now, when I spoke about adolescents being a special population when diagnosing PCOS, this is also an important part of that, because adolescents or teens will usually have polycystic-like ovaries. So the scan is not as effective in diagnosing PCOS in adolescents as it would be in adults. So besides looking for these three hallmark characteristics of PCOS, we also will assess for other anomalies that would be present in patients with PCOS, such as insulin resistance. So to measure insulin resistance, we would look at both glucose and insulin levels at the same time. Patients in which we suspect a diagnosis of PCOS should also be screened for their cholesterol levels and for cardiovascular risk factors. So this thorough approach ensures that we're addressing the condition in a holistic manner. And as I said before, since there isn't a specific test for PCOS, other endocrine disorders must be ruled out before establishing this diagnosis. Conditions such as hyperprolactinemia, which is an excess of prolactin, thyroid disease, especially hypothyroidism, and our adrenal hyperplasia are some examples of other endocrine disorders that we need to address before we can establish a diagnosis of PCOS. Okay, so once we've established a diagnosis of PCOS and we're looking to treat the patient, or the patient wants to improve their current condition, we always have to think about whether that patient is interested in achieving pregnancy in short term, or whether she's not interested in pregnancy at the time. And this is going to make a very big difference in the approach that we have with that patient, but also in the treatment that we provide. So, for example, non-pharmacological interventions is something that we can use in both types of populations. But the pharmacological or the medications that we use to treat PCOS are going to differ greatly depending on whether we're trying to achieve pregnancy or whether we're not. But basically, since we're in a platform that is more oriented towards assisted reproduction, we're going to focus on those women that are actively searching for pregnancy. But I am going to mention that for patients that are not interested in pregnancy, in at least in the short term, we do look for certain contraceptives that, aside from birth control, also offer an improvement in that hormonal imbalance that we were talking about. All right, so we should begin with non-pharmacological interventions, or basically lifestyle changes. So lifestyle changes is the cornerstone of PCOS management. A balanced, low-calorie diet paired with regular exercise of about 150 minutes per week of moderate activity can improve symptoms dramatically, even in the absence of actual weight loss. However, losing from 5 to 10% of your body weight can help us reach a more tangible improvement. And this improvement can even be seen with an improvement in your regularity of your periods, but also in terms of the hormonal imbalances that may cause acne or excessive hair growth, or any of the symptoms of PCOS. So this is one of the most important interventions that we can have with a patient. And also, we have to remember that lifestyle interventions aren't just about fertility, they're about long-term health, as women with PCOS are at an increased risk for developing cardiovascular disease, type 2 diabetes, metabolic syndrome, depression, and anxiety. Okay, and speaking of the pharmacological interventions or the medications that we can provide to patients, we usually start with certain supplements. Since, for example, vitamin D deficiency can, at least theoretically, exacerbate PCOS and can trigger an inflammatory response, it's always important that we address vitamin D levels by measuring them. And if there is a deficiency, it's important that we provide enough vitamin D supplements to compensate this deficiency. And this is especially important in certain times of the years, as you can imagine. Autumn and winter are where we might have an uptick in the amount of vitamin D deficiency that we may have. Now, inositol is another supplement that we can provide, and inositol has shown promise in managing PCOS as it improves insulin sensitivity and regulates the ovulation function. So this offers a more natural way of achieving similar results as other medications that we'll speak about. And lastly, resveratrol can act as a potent antioxidant, as there are studies that show that there is an increase of oxidative stress in PCOS. However, it is important to point out that out of this list of supplements, only inositol in both of its types, such as myo-inositol or delta-chiro-inositol, inositol is the only supplement that actually appears in the guidelines for managing PCOS in the European Society for Human Reproduction. Now, when we talk about the actual medical interventions, one of the very first medications that we need to remember is metformin. So metformin is usually used in to treat diabetes, more specifically, usually type 2 diabetes, but it also has a role in managing PCOS. So the main action pathway of metformin would be to improve insulin sensitivity, and this can help regulate cycles and support ovulation. However, it's important to point out that it's not for everyone, as gastrointestinal side effects are common when taking this medication. So it's always important to balance out the pros and the cons of whether or not metformin is right for you. It's also, and we can use this medication along with other treatments that we'll talk about. So it's always something that you can discuss with your doctor of whether or not it's right for you. We will usually indicate taking this in women that have a BMI over 25 kilograms. However, whether we can use it in women under this BMI is also an option, but you need to weigh out the pros and the cons of whether it would be right for you. Okay, so now we will be talking about the ovulation induction agents. So these are very important because, as I've said throughout this presentation, one of the hallmark characteristics of PCOS is that inability to ovulate. Okay, so we know that women that suffer from PCOS, some of them are going to go through long periods of time in which they don't ovulate. Okay, so this can be difficult for achieving fertility for two reasons. One, because it becomes very hard to know when your ovulation window is going to be, because you can never predict it. And also because if you don't ovulate, the sperm cannot get to the egg, and thus they cannot create an embryo that'll attach to your lining and then move on to a healthy pregnancy. So this is one of the more important therapies that we can actually provide, a way in which you can induce ovulation and achieve pregnancy. So for those pursuing pregnancy, ovulation agents such as letrozole and clomiphene can induce ovulation, letrozole is by far considered first-line treatment and the first option that we can provide. It's particularly effective, and when combined with metformin, it can yield excellent results. So you shouldn't take these agents without medical supervision, as we need careful monitoring to avoid complications such as multiple pregnancies. Okay, so when letrozole and clomiphene aren't effective enough or they don't work, there is another option that we can try, which would be second line treatment. And these are gonadotropins. Okay, so these are basically hormones that you naturally produce, but we will provide them at a slightly higher dose. Okay, so when we talk about gonadotropins, we're always talking about medications that are going to have an FSH or an LH effect. These are injectable hormones, and as I said, they are second-line treatment for women who don't respond to the oral agents that we were talking about. So these treatments do require meticulous monitoring via ultrasound to optimize outcomes and reduce risks. And now, speaking of assisted reproduction techniques that are going to use these gonadotropins, so are going to be an option when lifestyle changes and ovulation inductions weren't enough. So basically, ART options like an IUI, which is the intrauterine insemination, or IVF would be the options that we could consider. So women with PCOS can benefit from specific protocols in IVF, so they can go through a safe procedure and achieve the same results as other patients that don't suffer from PCOS. Okay, but before we actually try any of this, it's crucial to understand that the risks associated with pregnancy and PCOS include higher rates of gestational diabetes, preterm delivery, and hypertensive disorders. But with proper management and monitoring, these risks can be mitigated, ensuring a safer pregnancy. And also, I should mention that beyond pregnancy, it is important to remember that PCOS may increase the risk of developing endometrial cancer later on in life. So it is important that even if you're not considered pregnancy, you do seek medical help in managing PCOS. Now, when we talk about ensuring safety in patients with PCOS, when undergoing either IUIs, but more importantly, when undergoing IVF, it's very important that you remember that we're going to use specific stimulation protocols that either involve certain gonadotropins for a certain time period, but also the medication that we use is crucial to ensuring your safety during an IVF stimulation protocol. Okay, there are different protocols that we may use, protocols such as agonist protocols or antagonist protocols, and we are going to choose a specific protocol for to ensure safety during IVF stimulation. And also, something that patients can sometimes have a harder time discussing is cycle segmentation. So in patients with PCOS, we are usually going to try to stimulate your ovaries and do an egg retrieval, generate the embryos and freeze them so that we can give you a chance to kind of let your body shed all the hormonal stimulation that we had during the ovarian stimulation, and then transfer that embryo in a frozen embryo transfer cycle. So this is also going to help us avoid complications such as ovarian hyperstimulation syndrome. So when we talk about our take-home message today, we're going to remember that PCOS is going to be diagnosed when two out of the three characteristics that we spoke about are present, such as ovulatory dysfunction, hyperandrogenism, which is an increase in the male type hormones, and also a polycystic ovary image upon ultrasound. And also, we can use the AMH as an alternative for this particular ultrasound. Also, women with PCOS are at an increased risk for certain metabolic conditions, including cardiovascular diseases and also diabetes. And due to the anovulation nature of PCOS patients, it can also cause infertility. When we talk about treatment, we mentioned lifestyle modifications are an important part of treating people with women with PCOS, and also specific medications can improve PCOS. And by saying specific medications, I do need to point out that most medications are used off-label for PCOS. That means that the companies that make these medications, these pharmaceuticals, haven't applied for their use for PCOS. So most medications that we use for PCOS are going to be used off-label in most countries. And of course, to remember that ART, or assisted reproduction technologies, offer an effective treatment for women with PCOS. Okay, so I would like to thank everyone for their attention during this chat about PCOS, and I'd be happy to take your questions now.
Perfect. Thank you so much indeed, Dr. Abraham, for introducing us to PCOS and, of course, explaining what can help and what can work, such as medication, what kind of medication can be used as well. And now we will go for your favorite part, of course. As you know, we'll go for your questions. So please remember that you just need to type those in the chat and we will try to answer all of them. Don't hesitate. Of course, remember, it's all anonymous, so I can only encourage you to ask anything that's on your mind. A few questions are right here as well. Let me just start with the first one here from Emma, excuse me. Can PCOS differ from one patient to another, and what challenges can be expected for treatment?
Okay, so that's a great question, and that's something that we know very well. Patients with PCOS are very different, and that's why we've also established different types of PCOS patients. And we call these PCOS phenotypes. And we have four that are described in the literature. So there's a phenotype A, B, C, and D. And basically, these are going to be patients that are either going to present all the characteristics, for example, anovulation cycles, hyperandrogenism, and that polycystic ovary image. That's going to be, for example, type A. Whether the other phenotypes are going to just have two of these characteristics. So absolutely, this is something very well known. We know that there are different phenotypes. Treatment is going to be oriented to the type of phenotype that you may present. And yeah, this is a very important part of PCOS diagnosis. And also, it's, now that I'm talking about this, it's rather odd that many of the very important characteristics in PCOS aren't considered symptoms for their diagnosis. And when I say this, I especially mean insulin resistance, because insulin resistance is one of the more important parts of PCOS, and it's not considered at all for diagnosing this condition. So it's always important to look for insulin resistance whenever we're thinking of a PCOS diagnosis.
All right. Thank you so much for your first question. I do believe it was helpful for you, so thanks a lot, Dr. Abraham, for that. Can you share with us what brand of inositol would you recommend, or perhaps you cannot say that?
I can't say specific brands, and since it's also considered in a way as an experimental therapy, I'm not going to say any brand names. However, a lot of the supplements for preconceptive vitamins will include inositol, or at least the myo-inositol version.
Okay, crystal clear. Chris, thank you. All right, next question. Again, interesting one. So, do you believe alternative therapies such as acupuncture, someone wrote about reflexology, as well. So, can those complement pharmacological treatments?
So, okay. So the way that I think that we can approach an answer to this question
Mm-hmm.
is, do I believe? Yes, of course, we can all believe. However, when I have a patient in front of me, I always have to let them know whether there's evidence to support that belief. Okay. I do think that certain beliefs and also our state of mind have a hormonal translation. For example, we know that stress is not just a psychological idea. It does have a translation, especially with cortisol levels. So basically, with therapies such as acupuncture, they're not going to harm any other treatment that we're doing. So if it helps you personally, I think that it's an option that you can pursue, and it won't interfere at all with what we're trying to do in terms of both treating your condition and also achieving a healthy pregnancy.
Crystal clear and perfectly understandable. Thank you so much for your question. And let's have a look a few details here. Let me just display this one for you. I had stage 4 endometriosis endo removed from my bowel and endometriotic cyst removed 2 years ago, and had part of my bowel removed 7 weeks ago. This is after failed rounds of IVF and egg donation. What's the chances of natural pregnancy after these surgeries at 43? Anything you can suggest here?
Yeah. Okay. First of all, I'm sorry that you had to go through this experience. Endometriosis is a chronic condition, and it's very hard, especially when it's that advanced. So there are going to be certain aspects of endometriosis that we can see in PCOS, and some of these are going to be inflammation. Okay. However, there are certain supplements that we can use to kind of reduce some of this inflammation and some of this oxidative stress. However, managing endometriosis and managing PCOS is entirely different. And one of the reasons why achieving pregnancy in the context that you written just now would be that one, we always need to address the H factor and the impact that this has on the ovarian reserve, but also as an added negative value would be that the impact that endometriosis may have on the ovarian reserve, because I don't know if it has affected your ovaries at all, but if it does, and you've been treated through surgery with this, they might further decrease the ovarian reserve that you have available.
Okay. Thank you so much again for your explanation. Again, I believe it was helpful. Thank you so much for your question. Possibly our final question, because I don't see more questions coming up, but please remember, we still have time. If you have something you would like to add, go ahead, type this in.
I
And the
think
question,
they just typed one.
Yes, I want to ask this one. Just wanted to remind everyone. So yeah, I do see it, of course. So I have observed about 3 of my patients getting pregnant immediately after stopping COCPS used for regularizing in irregular periods. What could be the explanation? Are you able to
Well, by
elaborate?
COCPs, I'm guessing that you mean combined oral contraceptives. Um, if that's what you mean, I guess it would make sense that once they're not on the combined oral contraceptives, they would resume ovulation and then they would be able to achieve pregnancy. So so I think that once they have their regulated periods, as I said during the presentation, one of the harder parts of achieving pregnancy with PCOS is not knowing when they have that ovulation window. So by regularizing that, I think that you're definitely helping in achieving pregnancy. So that might be a part of it. Also, contraceptives act in two ways. One is that they'll increase something called SHBG, which is a sex hormone binding globulin. Okay, so this is going to pick up some of the free androgens or increased androgens that are circulating within the body. And by increasing SHBG, that's going to attach to the androgens and lower the circulating androgen levels. So that's definitely a way in which it would act. But also, depending on what oral contraceptive you were using, combined oral contraceptives are called combined because they're a combination of an estrogen and a progesterone. However, estrogens are usually always a type of estradiol, but the progesterone that the contraceptive has can vary, and some of these progesterones have a very anti-androgenic effect. So by further lowering those androgen levels, it makes sense that we would increase our chances of achieving pregnancy.
Again, thanks a lot for your explanation to this question, of course, as well. And 2 more questions, all right?
By the way, I know that some of these explanations when talking about hormones can be a bit confusing.
Of
So
course,
if you
absolutely.
need anything for me to clarify, go ahead and we can
Of
talk
course.
a little more about it.
Definitely. If there's anything you can simply follow up, just add the follow-up and be happy to of course explain it. And let's have a look. Let's have a look at the next one. So what would be the cause of excessive free fluid around the ovaries?
Can you
Yeah, sure. Let me show you
what would be
this.
the cause of excessive free fluid around the ovaries? In what context? Finola? Do you mean during ovarian stimulation or just normally? If you can give me a little bit more of a context, we can talk
In
about it.
general, in
Yeah.
general, she just added.
In general, well, there can be a small amount of free fluid within the abdomen that can be seen. Um, and also, we tend to see excessive free fluid right after ovulation. So that may be a cause.
I hope that answers your question. Of course, if there's anything else, you know what to do. And let's have a look. Next question, a few details again. So let me just show you this. So you mentioned letrozole as first medication before Clomid. However, my gynecologist, who is French, suggested Clomid, one tablet per 5 days starting day 3 of my cycle. I read a lot about women using Clomid, and it seems to work, and also to increase the chances of having twins. Anything you can advise here?
Absolutely, great choice. So letrozole and Clomid are they are both oral medications for ovulation induction. Now, you have to keep in mind that guidelines and recommendations are constantly changing. So when I spoke about letrozole being the first line treatment for ovulation induction, I'm actually citing the 2023 guidelines on PCOS management from the ESHRE guidelines. Now, Clomid and letrozole will have the same goal. Let's say they act a little bit differently, but they are both trying to induce ovulation. Now, back in 2012, I believe there was a trial called the Amigos trial that compared both letrozole and Clomid and found that they were both effective for to induce ovulation. However, letrozole had a slightly safer profile because it wasn't as associated to multiple pregnancies as Clomid was. But they can both be used, and yeah, it can be used starting on day 2, 3, 4, or 5 of your cycle, and we'll usually prescribe it for 5 days. And the dose can be anywhere from 50 to 150 milligrams, but it's usually on the lower end of the spectrum.
Okay, thank you. Again, thank you so much for your question and answer. All right, so you mentioned that some type of stimulation segmented is to reduce OHSS. Can the risk still be high for all PCOS patients or only, not sure here, severe one? Okay, severe ones. Let me show you perhaps, that'd be easier.
Mentioned that some type of stimulation segmented is to reduce OHSS. Can the risk still be high for all PCOS patients or only severe ones? So first of all, with time, especially over the last few years, severe OHSS is rarely seen nowadays. The dosages that we use for the gonadotropins for both FSH and LH have been greatly reduced. It's very rare to see doses above 450 units nowadays, and most will keep somewhere between 200 units to about 300, 375. So that's been a big change in avoiding OHSS in general. However, when we talk about when I mentioned specific protocols for patients with PCOS, I did mean sticking to these dosages, especially because PCOS patients tend to be what we call high respondents or patients that have a greater ovarian reserve. And this might cause a lot of follicles to grow. A lot of growing follicles will increase the amount of estrogen produced. And this increase in estrogen can cause OHSS. And segmentation definitely helps in that sense, because what we do is before the trigger, which is that final medication that we use to induce ovulation before egg retrieval, we will measure your hormones or count the number of follicles to get an idea of what type of trigger medication is going to be best to avoid OHSS. By measuring your estrogens, we'll know if you should better use a trigger medication that is going to reduce the risk of OHSS. And it's also going to tell us whether we should freeze your embryos and then transfer them at another cycle. Because if we were to transfer it during a fresh stimulation cycle with a higher amount of estrogens, a positive pregnancy is only going to increase these hormones and thus worsen the OHSS. So OHSS can always happen even with using all these measures, but it will decrease it dramatically by segmenting, using the right dose and specific trigger medication.
Brilliant. Again, thank you so much for yet another answer. So let's have a look. 2 questions are here. And I will go to the question that we see from our previous patient. Okay, so I take letrozole 3 tablets a day for 3 days, starting on day 3 of my cycle. Is that okay?
Yeah,
Yeah,
I took letrozole 3 tablets a day for 3 days, starting on day 3 of the cycle. Is that okay? Well, we usually use 1 to 2. But as long as you're being followed up and getting scans, I think that you can find the right dosage with your doctor.
Okay, hope that again helps. Thank you. How about this one? So PCO patients tend to have lower egg quality. Is there a way to improve egg quality in PCOS patient, for example? Yeah.
Well, egg quality is debatable, but yes, definitely there are ways in which we can improve our outcomes by improving the hormonal stimulation that the follicles receive. So, using medications such as metformin, um, and also the hormones that we were talking about, or the ovulation inductors, do help in improving egg quality.
Excellent. Thank you so much. Once more. Okay, what protocol you would suggest, yeah, for AMA 0.5, 843, 4-5 follicles?
Okay, so in this sense, so when we were talking about choosing the right protocol, we were speaking of a protocol that ensures safety by avoiding OHSS, which would be hyperstimulation syndrome. However, with a lower AMH and a lower amount of follicles, um, we have less of a risk of triggering ovarian hyperstimulation syndrome. So the best protocol is, the one that your gynecologist chooses for you. We wouldn't need to take those precautions in the same way that we would in a PCOS patient.
Excellent. Thank you. Once more. And I believe we will be slowly finishing. One final question, easy one for sure. So is Clinica Tambre open during holidays, Christmas time, etc. is coming? So
Well, we're certainly always available. I believe that we'll be closing on Christmas Day, but other than that, I think we're pretty much open every day.
yeah, exactly. So and so also remember that if you wish to get in touch with the team, you can either mail me directly, and I'll be happy to forward any of your questions as well. Someone is typing. I want to make sure that we've answered all of your questions, so don't hesitate. But I guess we will be finishing slowly. So thanks everyone for your time. Thanks everyone for joining us. Dr. Abraham, thank you so much. It was lovely to have you here. I'm sure it's not first just one webinar. I'm sure you will be back for some more, and there are plenty of topics we could discuss, I'm sure, with you as well. So thanks a lot. Before we finish, as you can see, there are comments. Thank you so much for this brilliant webinar. There are other great webinar, and of course everyone is thanking you also for answers, for all the answers. Excellent presentation. So thank you a lot indeed for that. Before we finish, any final words, anything you wish to add?
Just thanking everyone, for giving me your attention for these slides, and yeah, I'd be happy to come back in the future.
Thank you so much. We are definitely looking forward to it. So Dr. Abraham Zavala was our guest speaker today, fertility specialist at Clínica Tambre, and I'm sure we will meet once more right here as well. So thank you so much, everyone. Remember, it's being recorded, and that means it will be available on our website tomorrow. And I can only encourage you and invite you for our another webinar. And actually, we will be back on Monday, Tuesday, Wednesday. So it's definitely a busy time before Christmas. So I hope you will be able to simply join us. There are plenty of topics we still want to discuss this year. So don't hesitate. All you need to do is just go to myivfenses.com. All upcoming events and past events can be found right there. Thank you so much. Have a lovely evening and take care.
Good night,
Bye.
everyone.
Bye.
Bye.